So shall we use low or high calcium? Shall we use the low calcium in the treatment of adynamic bone disease? Does it have a really effect on the bone metabolism? Shall we use the low calcium as an antihypertensive effect? Can be used in the patient with resistant hypertension? Does it act on hypertension through the acting on the vasoactive substance in the patient on hemodialysis, leading to intravascular cardiovascular stability? Does it affect the PTH hormone, leading to worsening of the hyperpara through the stimulation? So what type of dialysate calcium shall we use? The aim of our work is to investigate the role of different dialysate calcium concentration on the level of parathyroid hormone and the cardiovascular stability. Patients and methods. This study was conducted in 80 end-stage renal disease patients. They are divided into two groups. 40 patients were dialyzing against low calcium dialysate path in Theodore Berhar's Research Institute. Group B, 40 patients were dialyzing on dialysate calcium concentration of 1.75, high dialysate calcium group in Qasr al-Aini hemodialysis unit. Patients were on dialysis for at least 6 months. The low calcium dialysate, group A, 1.25. The high calcium dialysate, group B, 1.75. We use Fresenius 4008, 4008 S, Gambro 95 and 96. All patients were dialyzing 4 hours, thrice weekly sessions. We adjust the blood flow from 300 to 350, the dialysate flow from 500 to 800 on the Fresenius and 700 on the Gambro, the temperature from 36 to 37. Filters used were polysulfone, low flux dialyzer, surface area reaching from 1.3 to 1.6. The ultrafiltration was adjusted to reach the ideal dry weight of the patient. Concerning the anticoagulation will start with 2,500 international unit of heparin as an initial bolus, followed by 1,000 international units per hour throughout the session. Exclusion criteria: we exclude the patient with unsatisfactory. We exclude the patient with unsatisfactory vascular access. We exclude the patient non-cancer with metastatic calcification. We exclude the end-stage liver disease patient, and we exclude patient with decompensated heart failure with an ejection fraction less than 30. We also exclude the pregnant ladies. We also exclude the lactating ladies. We also exclude the parathyroidectomy and the parathyroid ablation patients. After history taking and clinical examination, routine labs was done in the form of CBC, kidney function, ionized calcium, serum phosphorus, parathyroid hormone, and we calculate the calcium phosphorus product. We also do an ECG and transthoracic echocardiography for the detection of the valvular calcification. Regarding our data, we found that regarding the gender classification, most of our patients were male in group A and group B, more than 60%. Regarding the etiology of renal failure, we found that the diabetes and the hypertension, as was suspected, was the main cause of end-stage renal disease in all patients in group A and group B. Regarding the blood pressure, we found that there is no significant difference in group A and group B, but the systolic blood pressure in the high calcium dialysate group was higher than the systolic blood pressure in the low calcium dialysate, 129 versus 124. Regarding the hemodialysis duration, the mean hemodialysis duration in both groups were 4 to 5 years, and with no significant differences. When we compare the laboratory data between group A and group B, we found that there is statistical significance between the total serum calcium and the ionized calcium. Serum calcium was 8.5 in the high calcium dialysate, 7.9 in the low calcium, 1.13 in the high calcium dialysate, 1.8 in the low calcium dialysate. But the BTH shows non-significance. Although it is higher, the low calcium dialysate was 492, and the high calcium dialysate was 389. The B-value was 0.07, so there was no statistical significance. When we conduct the echo to see the valvular calcification, the number of valvular calcification in the high calcium dialysate group B was higher in the aortic, in the mitral, and of course of both. That lead to that the patients which have no valvular calcification were 25 patients, were double the patients who have no valvular calcification in group B. Statistical analysis of these data shows that 60% of the patients with no valvular calcification in the low calcium dialysate and 32% of the patients with no valvular calcification in group B, around the double, and this gives a statistical significance. We made a subgroup between the patient with valvular calcification and the patient with non-valvular calcification within group A. We found that the promoter of the valvular calcification was the phosphorus, and the calcium phosphorus product and the hemodialysis duration. And the same was in group B. The promoter for valvular calcification was the phosphorus and the calcium phosphorus product and the hemodialysis duration together with the PTH. When we see the calcium supplementation needed to maintain serum calcium, we find a significance in the patient of losing low calcium dialysate. They require high supplementation of calcium reaching 2.9 gram daily versus 2.4 gram daily in the low calcium dialysate. There was no significant difference regarding the alpha calcidol dose. Regarding the intradialytic hypotension, 22.5 of the patients of the low calcium dialysate passed to hypotension, while 15% of the patients in the high calcium dialysate passed to intradialytic hypotension with no significant difference. Our recommendation is to individualize the dialysate calcium concentration. That one regimen doesn't fit all, and this is still a pending issue, the dialysate calcium individualization, recently published in May 2012. Our recommendation that the optimal dialysate calcium concentration must guarantee cardiovascular stability, and especially the effect on the blood pressure, and must maintain normal bone turnover and mineralization, and is, with a special effect on the vascular and valvular calcification. Our also recommendation, don't forget to do echocardiography to all your patients prior to hemodialysis. And this was also recommended by the KDOQI guidelines for cardiovascular disease in the hemodialysis patient, which recommend to do initiation of hemodialysis when the patient just achieves the dry weight initially within the first 3 months of hemodialysis, and it is graded A. Further studies and researches are needed about the possibility of application of the dialysate calcium profiling. Dialysate calcium profiling, the use and its clinical implications. We recommend also to repeat the study on a larger number of cases and to include calcium mimetics, cinacalcet, non-calcium, non-aluminum phosphate bile, sevelameres, and patients with cardiac compromise or decompensated heart failure. Regarding the guidelines, the KDOQI guidelines, the dialysate calcium concentration in hemodialysis should be 1.25, but it was only an opinion. The KDOQI guidelines in 2009 say that we suggest using a dialysate calcium concentration between 1.25 and 1.5, but in 2010 there is a lot of arguments about this 1.5. They are saying that it will lead to calcium accumulation in hemodialysis patients. And in 2011, there was a letter of an editor asking about hard evidence for this high calcium. Regarding the European best practice guidelines, it didn't mention the dialysate calcium except only in the management in the treatment of intradialytic hypotension. It asked for adjusting the dialysate sodium to 144 and adjusting the dialysate calcium to 1.5. But take care from reducing the low calcium dialysate together with low magnesium in the dialysate 0.25, it will lead to hemodynamic instability. The National Health Service guidelines published in March 2012 use the low calcium dialysate in the management of calciphylaxis. This algorithm is how to individualize the dialysate calcium. First, to control the serum calcium by low phosphate diet and phosphate binders. If still not controlled, the use of vitamin D and the use of non-calcium containing phosphate binders, then we must if failed all of this to control the hyperphosphatemia, we must individualize the dialysate calcium. The low calcium dialysate will help to prevent hypercalcemia secondary to the high dose of calcium containing phosphate binders, but we must monitor for negative calcium balance. The high calcium dialysate will promote positive calcium balance, suppress the PTH levels, better hemodynamic stability, but there is a risk of hypercalcemia and there is a risk of developing a dynamic bone disease. Thank you. Happy Valentine's Day.
Thank you, Dr. Karim. Any question? At all, and we're always using the 1.75 and maximum you can